really gets at that big question that we all ask ourselves every day of how do we tell whether our patient is actually truly unconscious? And is being unconscious different than being anesthetized, or is the anesthetic state something that is very different? So definitely a very, very exciting panel that gets at the core of what we do every day.
Anesthesia management for endovascular therapy for stroke can be called a brain code. One needs to show leadership, knowledge and wisdom to get the best patient outcomes, and every second counts. When your pager goes off and there is a stroke patient en route to the emergency room and probably to the OR, as anesthesiologists, we need to start planning quickly.
The panel is aimed at treating obese patients. We're going to be talking about airway management, hemodynamic management, as well as using ultrasound for evaluation of gastric contents in obese patients.
We're trying to deal in an innovative manner with common controversies in ambulatory anesthesia and some not so common controversies as well. And these questions come up every day when we're taking care of outpatient surgery patients. So our hope is to provide evidence-based information for attendees that they can take away with them and hopefully make some informed decisions about patient care.
This is an important topic because it's a recurring theme in anesthesia that if anesthesiologists are to maintain their value to the healthcare system, they need to become experts beyond just taking care of patients in the OR or in the pain clinic. And through collaborations with primary care physicians, surgeons, pharmacists, we can extend our healthcare value, extend our reach outside of the operating room to really impact change in healthcare.
You know, hypotension is a big deal. When we don't appropriately manage hypotension, then every minute of hypotension under certain thresholds has the potential to cause organ system injury and to kill our patients in the operating room in the ICU. So it's a manageable issue. It's an issue that is in our hands as anesthesiologists and intensivists, and an issue that we can easily take care of with appropriate medications and interventions. So knowing this data will help us move the science forward and really prevent harm to our patients.
In this panel, we will be presenting the management of patients with left ventricular assist devices. These patients are becoming more common. They are not only at large academic centers, but they are also coming to private hospitals and an operating theater near you. And in this session, we will go over different ways to manage these types of patients such that a non-cardiac anesthesiologist can feel as comfortable as a cardiac anesthesiologist in caring for these patients.
Obviously there's an opioid crisis, but even for substances that are much less concerning, like cannabis, which is probably less dangerous than alcohol, there are many barriers, social, regulatory, and ethical, for researchers who want to conduct research with these. And we need more information to make well-based decisions about approval or distribution or prescribing of these substances.
Traumatic brain injury patients appear in anesthesia schedule for non-neurologic procedures such as spine or orthopedic injuries commonly. We cannot do a whole lot about the primary injury, but we can make a difference in patient outcome by avoiding secondary injuries.
So the key takeaway from this panel, it actually pertains truly to both men and women, but it talks about implementing change and making it a positive experience for people. And usually the two barriers to change are folks either working on something that they don't truly enjoy, and so that's one barrier, or not having enough resources. And so the panel talks about drafting an overall vision for change, making it meaningful, making it inspiring, and getting faculty to work on things they enjoy, and also organizing resources in a way that helps them to achieve their goals.
Now, under the pressures of healthcare reform and value-based care, many of us feel a little burned out and losing the connection to why we started to do medicine many years ago when we chose medicine. And healthcare disparity is a way to reconnect with why we're here. And so to think again about how healthcare is for everybody, in particular for the poor and those who need, and how we can do something and how we can connect to people who look differently, learn something about it, and feel that connectedness to our patients and to our colleagues who may be different from us can be enriching and grounding and reinvigorating when you have a really bad day.
We are on the verge of having more geriatric patients than we've ever had in the perioperative world, and our need to care for those patients as best as possible is paramount, and it's going to take a village to do that.
This panel will address 3 new developing technologies and how they can relate to anesthesiology basic science research. One will be on the use of novel, cutting-edge viral tools combined with optogenetics for probing neurocircuit function. One will be on next-gen sequencing, and one will be on the application of CRISPR-Cas9 technology to neurocircuits.
For more meeting information, download the 2019 Meetings app for iPhone, iPad, Android, and HTML5 for BlackBerry. Available in the Google Play and Apple stores.